The anterior cruciate ligament is the most frequently totally torn ligament of the knee. There is between 80,000 and 100,000 reported tears annually in the United States, with the majority in the age range of 15 to 45 years old while participating in sports. One thing that many people know is that females have a higher risk, up to 4 to 8 times, of ACL injuries than males in the same sport. There are several factors that contribute to this, including factors that are structural, hormonal, and neuromuscular. Structural factors include things specific to the ACL and the bony integrity around it. The female ACL is smaller in length, it's smaller in cross-sectional area and volume compared with the male ACL. The female's femoral notch height is larger, but the femoral notch angle is smaller than in males. The female's ACL is less stiff and fails at a lower load level. Additionally, adult females have greater anterior pelvic tilt, hip anteversion, tibial femoral angle, quadriceps angle, genu recurvatum, anterior knee laxity, and general joint laxity. Hormonal factors also play a role in the difference between males and females when it comes to ACL injuries. Some researchers have found that ACL disruption is greater during the pre-ovulatory phase of the menstrual cycle than in the post-ovulatory phase. Others have found the exact reverse. Some have also found that during ovulation itself, females have been at greater risk. It may be what is happening during the changing hormones that actually contribute to this. The third factor are the neuromuscular factors. Females typically display a more erect or upright posture when contacting the ground during early stages of deceleration tasks. They tend to have less hip and knee flexion. They also tend to allow their knees to collapse during landing. When they do land, this causes an increased mechanical advantage of the quad, and your higher quad activity during landing is an eccentric pull, which causes the overload of the quads pulling the tibia forward. There are some risk factors that are non-modifiable, the anatomy or the hormonal risk factors, but there are some modifiable risk factors that we need to think about. For example, neuromuscular risk factors such as strength, pre-activation and reactivation of dynamic restraint systems and flexibility come into play. And then biomechanics. If these things could be changed, we may find a decrease in ACL injuries, especially in the females. 70% of all ACL injuries are non-contact. Usually it is due to a deceleration, a rotation, and acceleration. Oftentimes it will happen during landing maneuvers when the person lands with their leg hyperextended, and it can also occur due to axial loadings. The other 30% of ACL injuries happen due to contact, and that contact can be a forced hyperextension. It can be an extreme varus or valgus stress being placed upon the knee, or an opposing player lands on the back of the lower leg. Signs and symptoms include joint effusion, usually within 2 to 4 hours of post-injury. However, that is not always the case. The ACL is unique in that it is intracapsular but extrasynovial, so it has its own synovial lining, which is why you sometimes won't see that swelling. There is hemoarthrosis or blood in the joint. Unfortunately, we really can't see unless ecchymosis starts to appear. In about 40% of all ACL injuries, there will be an audible pop. The person will complain of deep knee pain with a lucid period following the injury. and the person will complain of instability and or giving away of the knee with cutting. Range of motion will be decreased due to joint effusion. The gold standard for ACL testing is the Lachman's test. You can see from this chart there are other tests as well, such as the anterior drawer and the pivot shift. Because many of your ACL injuries do not occur isolated, we oftentimes will do other exams as well to test for anterior medial rotatory instability or anterior lateral rotatory instability. The Slocum test will test for both, as will other tests such as the lateral pivot shift. Additionally, the jerk test will test for that anterior lateral rotatory instability. Diagnosis is going to be through an MRI. If an X-ray is taken, a Sagan's fracture may be shown, and this is a posterior lateral corner avulsion fracture. This can be picked up through a dial test or a tibial external rotation test. Treatment for ACL is generally going to be surgical. Before I talk about that, I want to explain a little bit about the ACL. The ACL itself does not heal on its own. It has a thin vascularized envelope that is formed by the synovial lining. When that envelope is torn during injury, the blood dissipates within the joint and it does not form a local clot, preventing it from actually healing. There are individuals that will go the non-surgical route. These people are copers, and copers just means that they're able to function without having that ACL. Now, this is not a common outcome, and a lot of times the surgery is done before anyone realizes whether or not they really could be categorized as a coper. Surgery for ACL is usually going to be a reconstruction because repair generally leads to poor results. There are two different types of reconstruction. The first is an allograft. An allograft is going to be a donor source other than the self. Usually that's going to be a cadaver. The cadaver donor will create a bone patellar tendon bone graft. They'll use an Achilles tendon or a bone ACL bone. Prosthetic ACLs have been attempted, but they are not successful to date. An autograft is a self-donor. Usually autografts are going to come from the individual's patellar tendon, the hamstring tendon, or the iliotibial band.